So good evening, everybody. My name is Matt Harvey. I'm the Chief Officer of Liverpool LPC, and I'm here this evening to talk through the process. Now, initially, it's going to be the hospital end. We've just been shown that, so I'll whiz through that a little bit. But this is on screen now a virtual hospital that we have set up with PharmOutcomes, and this is going to send through a live referral to our virtual pharmacy, and then I'll log into the virtual pharmacy through PharmOutcomes and then show you the process. Okay, so that's what we've done this evening. Excuse my voice, I'm about to lose it, so I will try my best not to. If you can't hear me or understand me, then please shout, and I will try my best to speak clearly. Okay, so this is in the hospital. So we have our patient, Del Cooper, who's under the consultant Diane. And it's a planned admission. Okay, so this is a screenshot of JAC, which is another hospital system, just like pharmacies use different PMR systems. This is JAC, which I believe is different to the one that's used in Countess, but it still integrates into PharmOutcomes. Okay, so if I just whiz through these bits and pieces. So again, on this system, the hospital can write down any allergies and sensitivities to patients, so you'll know that the patient's sensitive to clarithromycin, gabapentin, etc. And here the hospital has written down the medicines that the patient's being discharged on, okay? And this is the information that's going to ping through. So as Chris has said, you're not going to get a PDF of the discharge information, but what we're going to get in pharmacy is the information that we need to do our job in making sure that Mary gets the correct medicines and doesn't get medicines that's been stopped, etc. Okay? And it all pulls through automatically. So in this note, this is where Chris mentioned before, the hospital can, in this field, free type and send messages. So it could be, please give Mary a blister pack, or whatever else it may be. So additional notes may free text into the discharge as well. Now, it's also very important that the pharmacy is selected. So as we know, across Cheshire Merseyside, there are 633 community pharmacies across Cheshire Merseyside, all with our individual F codes. So it's really important that the hospital chooses the correct pharmacy with the correct F code. If they don't, then it's going to get sent to the wrong pharmacy, and that's not good for your IG lead. So in this instance, I have an F code for the pharmacy, which I'll type in. You'll notice that it's not got an F on the start of it, but we'll ignore that a little bit. And we'll discharge the patient. Okay, now, that discharge has now been sent through to PharmOutcomes. Okay, so what you'll notice is there's two ways that you'll know you have a notification waiting for you. Okay, the first is via email. So hopefully, if I click onto my emails, and refresh. It does take a little while to come through sometimes, so I'll go back into that in a minute. An email, I've tested it 5 times a day, and every time the emails come through, so I've got every confidence the email will come through. Talking of emails, it's really important that you have an email address linked on PharmOutcomes. So if you go onto your settings, you can ensure that you have an email address that messages, etc., get sent through to. If you have an NHS Net address, if you're one of the lucky few that's got their NHS Net address, I would strongly advise that you use that email address as your set email address, because that's not going to change. Because we know in some pharmacies, we have the old, like I'm using Gmail there, we have at gmail.com, at yahoo.com, they're not very safe and secure websites to be linking an address to. Any colleagues from Boots or Tesco's who don't generally have a pharmacy-specific email address, and you have a personal email address, and you move to a different branch, and that store suddenly doesn't have an email address associated to it, if you move stores, you'll get that notification to the new store, not the one it should be going to. So please, 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 once you have your NHS Net email address, please, it's turned up, happy days, please use that as your email address. Okay, so you'll see here that I have an email from Pinnacle Help Desk. I click on that, and it tells me that I've been sent a referral So as you've been sent a referral request from the virtual hospital, so this will, for you guys, say, count as a Chester hospital, or if it's a different hospital in your locality, if you have either in a pharmacy that gets covered by more than one acute hospital, or indeed the mental health trusts, Association Rural Partnership, etc., it will tell you where it's come from. And it'll invite you to click on the link. So you click on the link, and it will take you straight to PharmOutcomes, okay, in which you'll log into PharmOutcomes. You put in your usual bits and pieces, okay. There is another, even more exciting way that the system will tell you that you have a notification, and that is being demonstrated lovely by my colleague here, Hassan. Can you see this blue flashing light? Hold it up higher, hold it up. This is what's called, wait for it, a pharma alarm. Now, I think the bloke or lady who thought of that name needs a medal because I think it's amazing. So a pharma alarm is a USB stick that plugs into your USB port in your computer, in your pharmacy, and as soon as the pharmacy notification referral gets sent through, that thing will start flashing. So it means you haven't got to be checking your emails every 5 seconds. Not that we're going to be getting that many referrals in a day. I mean, you might get a couple if you're really busy. It's not something that you're going to be getting an awful lot of necessarily if you think there's one hospital discharging to a lot of pharmacies. But just to aid you in your kind of jogging your memory to keep checking for referrals, pharma alarm's there. It'll start flashing and go, woo, and off you'll go. You'll know to check your emails, log straight into PharmOutcomes, and there it will be for your action, okay? This will also work for any other forms of referral. So if you're a pharmacy that's using or offering NumSAS, the new NHS Urgent Medication Advanced Service, I got it right. Again, because the referrals are being sent via 111 through PharmOutcomes, as soon as the referral is sent through, it will start flashing as well. So if you've got some staff on the Saturday that can't get into emails and stuff, they'll see that flashing and know they've got to do something about it. Okay, so if I log into PharmOutcomes using my 6-letter, if I remember it.
I wrote it down.
Have you? So this is PharmOutcomes. So I'm now on the virtual pharmacy. So you can see at the top here, it says virtual community pharmacy. Normally that would say Joe Blogg's pharmacy with your F code. So just have a look when you log in next and you'll see what pharmacy you're in case you're wondering what pharmacy you stood in. You click on the services tab, and this is how many times I tested it today. You get all these referrals pop up. So these are all the referrals that have been sent through. In this instance, all the same patient, giving all the same information, because I've only got one patient on the virtual hospital pharmacy. But it has different statuses depending on what's happening there. So if it's a pending referral, referred to you. So all of these that are saying referred to you haven't yet been actioned, whereas this one has been accepted. And I'll show how I do that in a minute. So these are all the same, but you may log on and you may have different patients. You might have DC, AD, JB, etc., etc. So you'll know these are all different referrals from different patients. You need to click on the referral, so I'll check the top one, click on that, and up the information will come. So it gives us all the information we need. So it gives us when the referral was made, where from, if there were any doubt as to which hospital it's come from. The patient demographics, so Del Cooper, who's 63, he's a male from Manchester somewhere by the looks of it. And again, who the consultant is and where they've been discharged from in the hospital. Underneath that, it will give the sensitivities. So we can see, as I said before, they had shortness of breath with clarithromycin. They also have pruritus with gabapentin, and have had acute kidney injury with factor 9. Underneath that is, I suppose, the thing that we are going to be most interested in a community pharmacy, and that's the medicines they've been discharged against. So that is when you look at the lists and reconcile it with the PMR or the prescription that's sat on your shelf from before they were admitted, and check to make sure that Mary is on the same meds, and if not, then you need to do something about it. So what you do is, when you've reviewed all that, is check that Mary is your patient, or in this case Dale is your patient. So if you're not sure, just check your PMR to make sure it's one of your other patients. If it's been sent to you incorrectly, so the hospital's typed in the wrong F code or whatever else, then you have a way of rejecting it and sending it back. And by that, you click reject referral, okay? So if Dale or Mary, whoever the name of the patient is, has been sent to you incorrectly, so that's not your patient, it should have gone to your branch that's down the road, then you can type in this box in here, so you can select that and start typing, oh, not our patient, should have been sent to our branch down the road at 33 R Street or something like that, or whatever. And then you press reject referral, and then that will ping back to the hospital, and that's all you have to do with it. Okay, so that's been rejected. So we go back onto it. Of course, if you've rejected it, you won't be able to go back onto it, because I've sent the same patient through that many times, I can just do this. You can then accept or complete now. So if you accept it, that generally means, you can see now, rather than referred, it's got the user who's accepted it, okay? So my name has come up there because I've accepted it. So oh, and the colour changes. Hey, oh, I haven't seen that before. It gets better. This is making my life this, as I tell you. So the colour changes on PharmAlarm. Oh, well, there we go. So you'll know if you've started actioning a referral, because you'll have the username who's accepted the referral there, whereas if you haven't, it will still say referred. So you'll see here it says accepted, and there it says awaiting follow-up action. So nothing's happened to that patient yet, okay? Now you accept when the patient's not there, but if Mary's kind of bounded in, or Dell has bounded in from discharge saying, oh, I've just been discharged, I need a prescription please, and the patient's there, that is when you can then complete, okay? And there's a few little bits of information that the system will ask of you in order to completely complete and close down the referral. And that's really just to get some outcomes, you know, what's happened as part of this referral, have you given a blister pack, was there any adverse drug reactions, etc., etc. I'll go through that now, okay? So if we go back onto the referral, if it loads up, there we go. So rather than press update, you'd complete now. And then all the boxes and stuff that you need to do something with will come up underneath. Okay. So it goes through. So were there any side effects or adverse drug reactions with the medication that they've been on? So Mary or Dale, in this instance, has been discharged now for a number of days. They've been taking the medicines that they were given in the discharge lounge by the hospital pharmacy. So they usually get, is it 7, 12, 14 days of medicines on discharge? So they've been taking those, and she's come in for the next prescription now. So she's been discharged, and she's come in to pick up her next lot of prescriptions. So that's when you ask her, have you had any problems with the medicines that you've been discharged on? Now this is perfect for you for discharge MURs. We know that an absolutely tiny percentage of the overall number of MURs are discharge MURs. You now know every patient that's being discharged that's had a change in medication, every single one of these patients that have had a change in medication are suitable for discharge MUR. Okay, and that's one of the target groups, so it's even better. Okay, so ideally you would undergo a discharge MUR with this patient if they've had a change of medicine. It may be that it's a new medicine and they can take part in the new medicine service instead, at which point, as we know, unless it's an intervention MUR, we'll then do an MUR after 6 months. So whichever service Mary, or in this case Dale, ends up on, we need to check, and we would probably do as part of the discharge MUR or the new medicine service anyway, have you had any problems with the medicine, any side effects, any reactions or anything to it? Hopefully it'll be a no, but as we discussed with the stats before, there's a very good chance it's going to be a yes. So if it is a yes, other questions will pop up underneath. So it will ask, was it manageable and non-harmful? So can the patient continue on this? Or has the patient stopped taking the medicine? And if so, it will ask to be the patient to be referred to the GP. And as we know with PharmOutcomes, it will automatically generate that notification for you and send it electronically via NHS mail as long as the doctor surgery has got the NHS mail at their end. If not, it will ask you to print out and send, just like we do for flu now. Okay, so if your surgery, it sends it automatically, it will continue to do so. If it will invite you to print it out, then you do that. So I will say yes, that she's had some adverse drug, or he's had some adverse drug reactions. Do we need to submit a yellow card? Yes or no? Yeah, she's had some ADR, but we know it's a known reaction. It's not a new drug, so we haven't got to. If we did want to submit a yellow card report, then there's a link here, so you can click on the link, and it'll take you straight through to the yellow card site where you can input the data there and then. Okay. The system then asks you what advice you've given and support you've given. So have you done the new medicine service? Have you done the discharge MUR? Have you reconciled the medication? Have you checked the prescription that Mary or Dale have come in to collect is matching what the discharge is telling you? Are they on the medicines? They've been stopped because that was the reason for admission in the first place, etc. And if you notice any differences there, then that is when you need to be checking with the GP and getting clarification as to why that item is still on the prescription. Of course, Mary may not be here. She may be housebound after the stay. So you may be able to do an MUR or an NMS on her at home as a domiciliary or over the phone, potentially. We'll talk about that a bit more later on, about how that can potentially happen. We are working around steps about how we can do that without being too burdensome for the pharmacy. So it may be that you need to check the summary care record. So if you haven't got a prescription there, and you need to check to make sure that the summary care record, which is matching the GP record, is correct. So that could be another instance for you to increase summary care record use, is to check the summary care record against the prescription and the discharge to make sure they're all singing from the same hymn sheet or script as it is. So it asks some very generic things. So have you given large print labels, talking labels, easy open tops, etc., etc.? What have you done since Mary or Dale's been discharged to help them with their medicines and the medicine optimization? So you tick all the boxes that you need to. Have you given a flu vaccine? Have you done the stop smoking service, etc., etc.? It'll then ask you, has the prescription or repeat available? So if you click yes, it will say, does the new repeat match the directions in the hospital discharge? So again, it's another thing, just check the repeat slip or the prescription or the summary care record against the discharge to make sure that any necessary changes has been made at the GP surgery. Okay. So I'll just say, yes, it was correct. And because she's had some adverse drug reactions, I will say that the referral is necessary, and then you select the practice. So this is live, so I won't choose a actual doctor's surgery, so I'll send a random patient through to them, they won't be too pleased. But this is a test surgery now that Pinnacle have set up. So that notification, because it's come up as green, so you can see that, you might not be seeing on the screen, this is slightly green now, so that will send through as an NHS Net email, so you haven't got to print it out. If it needs to be printed off, it should come up there saying that this surgery hasn't got an associated NHS mail account, so you need to print off this notification. And any referral information, so that is where you would say, oh, Dale has had a problem with the atorvastatin myopathy or something. We'll just choose that because it's the top of the list and it's a common complaint. So you type in there in the free text box at the bottom there, Dale's had myopathy. He stopped taking his atorvastatin. Okay. And then the last box is asking the general questions that get asked at the end of an MUR. So as part of this review, has a patient got a better understanding of their condition? So, and it breaks down to cardiac condition, diabetes, respiratory condition, the purpose of the medication, when to take or use the medicines, and how to take or use the medicines. And there's another box there as well. So you can tick other, and if you tick other, then please input what it is that you've done to make them have more knowledge about their condition or medicines. And then you press save. Okay. Now that will then ping across the referral to the GP. It will then notify the hospital that you've done the referral. So we will be keeping tabs on lots of unactioned referrals just to see what's going on. It might be that Mary is housebound for a couple of weeks because she's had a hip replaced or something, or what have you, and she can get out next week. So you've organised the review with her. You're going to do a discharge MUR on her, but it's not till next week. That's why it's still left there pending. So we we will be keeping an eye on things to make sure, especially at the start, because for all of us it's a new thing we have to keep reminding ourselves to look at and do. So it might be that some, at the start in particular, don't get actioned, but we're going to hopefully be supporting you all through that to make sure that we are picking up the referrals and actioning them as and when we can do. And that is pretty much the patient journey through the pharmacy. Any questions or anything about that? Yes.
Just a quick one. I noticed on the referral, it doesn't mention the patient's GP at all. Now, is that a conscious decision? Because it seems a bit strange to me in that if we're getting a referral for a patient, and the patient might be known to us, but we might have seen them for ages, and it doesn't mention the patient's GP anywhere.
The reason behind that is the hospital. We had a discussion about this yesterday, in fact, and it got changed at the last minute because it did used to say the GP surgery. But if the hospital, if it said the GP surgery in there, there was no way of us then inputting the GP surgery on where the referral should have gone to. And so if the hospital had not put a GP in, you wouldn't have been able to send a referral. And that, at our end, it just wasn't working properly. So it's been a last minute change all as of yesterday when I was kind of being shown how this all works and the patient journey and everything. I thought, well, hang on a minute. You know, if and Kevin from PharmOutcomes, Kevin Noble said, well, that's a very good point actually. If the hospital put the wrong surgery in or they don't put a surgery in, then we're snookered at our end. We can't do anything about it. So that's why the GP surgery isn't in the discharge. But hopefully you'll have the script there so you know exactly what GP surgeries are in. Yeah. Or on the PMR, it should be updated if the doctor changes. You should update your record anyway.
Does your discharge note mention the items that have been discontinued as well as the ones that have been added?
I believe so.
Only if it's free type. It won't pull that information in automatically because from the electronic patient record in the hospital, if they've come in for surgery, for example, they might have an order set for antiemetics, laxatives, painkillers, all sorts of different things, and you just get a long list of 15, 20 things that mean nothing. So what the expectation is that the pharmacist who's been looking after the patient while they're in hospital will make a free type entry saying what's been stopped, where it's particularly relevant.
Is there sort of a report?
That should, I think, in this box here, any free type text. You see, when I demonstrated the different system, I could type a message to the pharmacy. That free type will transfer into the system. But I suppose if you've got a prescription that's got a torvastatin on, for example, and from when the patient was prior to admission, and it's not on the discharge list, then you'd assume that it's been stopped. So it'll be one of the things that you would perhaps query. So anything that's not on this list, you would assume the patient's no longer taking it. So these are the medicines that the patient's been discharged on. So that really would be what you'd assume that the patient would be taking on discharge.
Yeah, can I just come in there for a second? So patients' medicines are reconciled on admission and at discharge as well. So when a discharge prescription is generated, we'll check it against their inpatient prescription. So if they're not taking it anymore, it won't come through. So I think I heard someone say assume in a sort of questioning way. I think it'd be a pretty strong assumption that we've got that right because that will have been checked before the discharge prescription was released.
Sounds like the community pharmacy will have to do reconciliation as well at our end. What sort of time scale are GPs expected to turn this around? Because I know we do a lot of firefighting and we're waiting for prescriptions before we can carry on with this process. Where do we feed that back?
So when you're doing the reconciliation and you're seeing the patient, if that prescription is different to the discharge, then that is when you'd be going back to the surgery with some conviction now, because you've got the thing in front of you saying, I know this patient has been changed and this has stopped and that's been changed to X, Y, or Z. And then you say, well, I've got the discharge here. If you've got the discharge, they should also have the discharge. Whether they've actioned it at their end yet, that's a different story. And I appreciate that some surgeries are faster than others.
Is there a button on there that, you know, if your MDS patient, we usually have now going being discharged, which is great, we knew that you knew on admission.
Yep.
But we're now on the timescale to turn this around to get help for the patient, and it's not been mentioned.
what I would say in that instance is you'd need to phone the surgery to get something done quick, because if you free-typed it as a referral to go back to the GP, you've then got to wait for them to pick up that referral and then scan it and then process it, which will be down the pecking order of what they would have had anyway with the discharge. You see, so picking up the phone and saying, I've got this discharge here dated the 12th, they can quite easily see on their systems whether they've got a discharge dated the 12th, hasn't been actioned yet. You know, a doctor or prescriber, pharmacist, nurse, whoever can look at that and then make any necessary changes in order to get that prescription over to you.
Appreciate what you're saying. This has been evaluated, this service, so is it not worth an evaluation of the amount of work we are doing, picking up the phone, it's not being captured?
Over to you guys, that's yours.
I thought so, yeah. Thanks, Matt. Now, this is one of the things, I mean, currently, the whole point of eTCP is to provide the information, because before you was basically throwing a dart in the dark and don't know what you're hitting. At least you now got the information. One of the things that we're hoping this program would show, the value of community pharmacy being armed with the information, having real impact on quality of life of our patients. Okay, so what we're hoping to do is that community pharmacists who work very closely and very well with their GP colleagues, GPs are notoriously, there's no GPs around here, is there? No. GPs are notorious. I can say that because I actually work across 8 GP practices, so it's not a problem calling them. Nobody saw me say that, right? So basically, the community pharmacy, the GPs have got this lag of addressing the discharge changes. So there is potentially, working with CCGs, working with GP practices, that community pharmacies could be that missing link to provide GPs actually with discharge reconciliation. So when you do your MURs, that could actually go to the GP, who would do their post-discharge reconciliation and generates the correct prescription. But that's long-term, not just happening yet, so in terms of funding.
It's not happening yet, but I know I've had discussions with the CCG in Liverpool about this, and they're very interested in letting pharmacies do that as a commission service. So it's something I'm currently working on. I know that my other colleagues in the other LPCs are also talking to their CCGs about it as well. One thing that may answer your question, that I forgot to mention in my presentation, is here. So is the repeat correct? So before I ticked yes, if it's no, then it will ask you why it's not correct. So going back to the evaluation, it will say, you know, and that's how we would collect that data. Yeah. Yeah, so that's where you would capture it. So you tick the reasons why that repeat wasn't right. Okay, and that will go into looking into the evaluation, then look into what we've done then to change that. All right.
I'd make 2 observations. The first is that the overnight processor that runs all the reports sends a report to you guys, but it also sends the similar report to GPs. So what they get should match what you've got, and they should get it at the same time the following day. So if you have a query, they should have the information. They absolutely should have it. And I think the second thing is, I think it's really important that the point you raise, because we know it's an issue that sometimes patients' prescriptions aren't changed when they go to the GP for a repeat once they've been in the hospital system. And perhaps for the first time, we're going to get to a situation when we know how big is that problem. And once it's more sort of visible and we can measure it, then we can start to work on improving it. And we've got some measurable outcomes to say, actually, the steps we've taken to minimise this problem have been put in place and they are working or aren't working. So, yeah, that's one thing that hopefully this project will really help with.
Thanks, Chris. If you've got any other questions, if it's very quick, I'll come to you. And then Andy, I want to invite Andy to say 1 minute or a minute and a half on evaluation. So we'll go to that lady. You've already had one question, sorry.
My question is, I just want to try and understand it. So we get the notification, we accept it. Yeah. If this patient is a patient that we manage their prescription, can we request the new medication if there are changes directly from the, do you get me? Can we just make a request of the new one, get the prescription, get it into blister pack or whatever our decision is, get it ready within the 1 week that the patient will finish using the one they got from the hospital?
I presume you talk to Mary or Dale that you know, how much medication they brought from hospital with them, when they're going to run out, and then you communicate that with GP. And Matt just showed you going through that. At the end, you would generate something to the GP, and in that you could say, please issue the next prescription according to discharge, etc. There's a free type, isn't it, Matt?
You could do. The only thing is whether the GPs would pick that up quicker than you've just finger up the phone and asking them for it. I'd probably still be quicker to pick up the phone and ask them for it.
Assuming the patient is not one that we manage, maybe
Yeah.
just an electronic, patient that they order their medication on their own. What do? Do we wait until the patient comes in, knowing that the patient might run out before they come in?
Well, if the patient orders their own medication, then it's up to the patient, isn't it, to manage their own repeat and order that prescription before they run out of the medication, just like it is now. So it doesn't matter.
Bring them to communicate with them that check.
Well, they all know that the medicines have been changed, you know, because they're now taking different medicines they weren't taking on admission to the hospital. So, you know, they will know that the medicines have changed, and they'll be, when they run out of what the hospital's given them, they do, I work in GP practice as well, they do come to you and, as the prescriber and go, here's a box that I got given, here's the Optiv eye drops, whatever, and you think, well, hang on, where's the letter here that says they're on this now? You know, you try to go through it, and if you can find the information, then you'll issue the prescription for them to carry on with. So that is the sort of thing that would happen now. So if you're managing the patient's repeat, then yes, you need to obviously order that. But if they're ordering it themselves, then you've got no obligation to it for them. You know, it's, you know, all about patient, you know, centre care and all that, and the patient should be doing it themselves and all that jazz.
So we're not like to do that on their behalf.
No.
Thanks, Matt. Andy, do you want to quickly say something about evaluation? And if you write your questions down, I know, but we want to get Sarah and Emma to get Sarah. I just was looking for you to see where you were. They need to do the case studies, and then there is a Q&A just after them. So then we'll bring you back, Jazz. Okay, if you have any other questions, then okay, Andy, quick.
Thank you. It's just to pick up sorry, I don't know the lady's name over there. The Liverpool John Moores University Pharmacy Department are doing an evaluation of the programme in 3 phases, really quickly. Phase 1 is learning from the 2 pilot sites, the process evaluation of what can we learn from Chris's team and from Karen's team over at Leighton in terms of what can we do better when we roll out across 10 hospitals as you'd expect. We're doing qualitative interviews with key staff. The second phase is to look at the outcomes that was described by Hassan. Have we actually realised, for example, reduction in bed days saved, reduction in readmission rates, etc. Now, the point you were making is the increased workload between the referral blockages, in inverted commas, between GPs and pharmacies. Now, we can actually do something about that. So if we discuss that after the meeting, we could probably put that into the phase 2 evaluation and look at the extra workload that that's generating.
No. And this is going to give us the evidence. One of the problems with community pharmacy workload is that nobody ever measures it, so nobody can actually quantify it when it comes to negotiations, to commissioning, etc., etc. We now, for the first time, we've got tools to measure this. Okay, thank you very much for that. Sarah and Emma. Right, I'll pass the mic to Sarah and Emma.
Okay, so no slides for this part of the evening. It's kind of over to you guys, and we've got a chance to discuss. So just I suppose just a second or two just to reflect. So we've heard about the background to this service. We've had a live demo, so you can actually see what it looks like. But Emma and I are going to help you put this into context for your pharmacy. What does this mean for you going away from tonight's event? We know we don't always get it right for Mary. I think we can probably all agree with that. It's widely accepted and acknowledged that between 30 and 70% of patients have an error or an unintended change to their medication where they're discharged. That is a staggering figure. That's a huge proportion, really, and we can make a difference. We can improve things. So, you guys are, pockets of the country that have this technology. You are really leading the profession in supporting patients to another level at the point of transfer of care, at that point of discharge. So, firstly, our first activity is to try and draw out some discussion around some enablers. So just reflect on the things that you've heard so far. Is anything holding you back at this stage? We've had some questions, you've raised some concerns about perhaps communication with GPs, but just think, in your tables, have a quick discussion. Think about all of the barriers that you can foresee to enable this service when you go back to your pharmacy. If you're a locum, think about your approach across a range of pharmacies that you go to. But in discussions on the table, think about all of the barriers, and then we would like you to identify the top 3 barriers and write those down on your flip chart that's on the table. So think about your barriers and then confirm your top 3 and write them down on the flip chart. And then we'll be rotating those round so that other people can identify and discuss some solutions to the barriers before the flip chart comes back to you.